myself Dr. Kirti, Assistant Professor, Physiotherapy Department. Today I am going to tell you about passive movements at the lower leg. So starting at the ankle joint. So at the ankle joint, there are four movements: ankle dorsiflexion, ankle plantarflexion, eversion and eversion. So starting with the ankle dorsiflexion. The patient position would be in the supine line as shown here. Therapist position would be side to the patient. Now the hand placement. For hand placement, with one hand, one can fix the lower leg just above the ankle, and one hand grasps the forefoot, means the big toe and the fingers. So for inversion, we can perform the passive movement like this. And for the eversion, again the hand placement would be same, but the movement would be like this for eversion, like this. Now for the ankle dorsiflexion, the hand placement again, the one hand fix the lower leg just above the ankle, and other hand would be on the heel of the uh, ankle. So to perform the movement, one can perform like this. And for the ankle plantar flexion, again, one hand would be again just on the heel of the ankle, and with the other hand we can perform the movement like this for the ankle plantar flexion. So next, moving towards the knee joint. So there is knee flexion and knee extension. So for knee extension, the patient position would be supine line. So in this position, one hand would fix the distal leg, and with the other hand just above the knee joint, we can provide the we can say stability. So in this way, we can move the knee into extension. Now, for knee flexion, the patient position can be supine or in the prone line. But for now, we can perform even it in the supine line position. So in the supine line position, again, the one hand would be stabilizing the distal leg, and with the other hand just below the knee joint, or just we can say above the knee joint, we can perform the movement like this. Or in the prone position, we can also do the movement. Now at the hip joint, there are 6 movements. So for the hip flexion, the patient position again would be spine line. Therapist position would be side to the patient, and one hand would be stabilizing the distal leg, and the other hand would be on the distal femur. And for the hip, we can say flexion, we can do this. In this way, we can perform the movement. For hip abduction, again the patient position supine line. We hold the distal leg, and just above the knee joint, we hold the we can stabilize the distal femur, and we can move the leg into abduction. And for the abduction, we can say for the adduction, we can stabilize this sacrum, or we can stabilize the pelvis, and then one hand stabilizing the distal leg, and then move into the adduction. Now for the internal external rotation, we can flex the hip to 90 degree, knee also bend to 90 degree, and now one hand would stabilize the distal leg, other here, or we can place it here also, just above the knee joint, and move into, this is external rotation and this is internal rotation. For the hip flexion, the patient position would be prone position. So we can perform that movement in only prone position. So now for the convenience of the patient, sometimes we have to perform it in the supine